the last two sessions before break, change of style a little bit, change of format, and I'm going to really hand the microphone over to Dr. Laura Bull to talk about nutrition and PFIC, but we're going to get a lot of different perspectives out of this talk. And so a really hot topic with a lot of interesting perspectives. So take it away, Laura.
Thanks. Oh, good morning. So my name is Laura Bull. I'm mostly a geneticist who's been studying cholestasis for a long time, but have recently become more also interested in nutrition and worked with Emily to organize this session. We're going to have a presentation by Dr. Sokol, who's going to give us sort of an overview of nutritional issues in PFIC, and then hear brief talks from Elizabeth Tamayo, who's a dietitian here, about the role of dietitians in managing PFIC nutrition, and from Sharon Munn, who's a mom with a child with FIC1 deficiency, and she's going to talk about her odyssey. And then we have some questions that were submitted prior to the meeting from families that we can address, and also, seeing how time goes, take additional questions from the audience. So Ron, if you want to go ahead.
First of all, for those of you who don't know, Laura Bull is extremely humble about herself, but Laura literally discovered the FIC1 gene, which got this whole ball rolling on the genetics of PFIC. And I think we should really recognize her accomplishment, but you'd never hear Laura say that. So I really appreciate the invitation to come back to Cincinnati. Here's where I did my fellowship in GI, hepatology, and nutrition a few years ago with Bill Ballestieri and many others. And while I was here, I got very interested in nutrition, particularly one of my favorite topics, vitamin E deficiency. But today what I wanted to do is provide basically an overview. Here's some disclosures. I consult with the same companies that everybody else does speaking at the meeting. I wanted to just review very briefly causes and consequences of undernutrition or malnutrition in cholestatic disease, focusing on PFIC, review a brief approach to how to assess nutrition and how we manage it, and then just say a couple of words about fat-soluble vitamin deficiencies and their management. So I believe everybody in the room here knows that cholestasis is really defined by impaired bile flow, which will lead to jaundice, build up of bilirubin in the blood, particularly conjugated bilirubin, but this also causes decreased bile flow into the stool. Bilirubin forms the major pigment in the stool, so stools may become pale, urine becomes dark as the conjugated bilirubin spills into the urine, liver may become enlarged, and we're all itching for a cure here on your bracelet. The itch starts. There's a number of pediatric cholestatic diseases, and really the final common pathway here is the decreased bile in the intestine from a nutritional perspective, irregardless of which disease we're talking about. But here's a list that may be familiar to many of you, as your child probably was considered for many of these diseases in the journey to making a final diagnosis. And this cholestatic odyssey, which I'm sure you have lived through, we've heard about several this morning, usually starts with jaundice, and then there's bile retention in the body, which leads to elevated bile acids, poor absorption that we'll talk about, et cetera. And the final common pathway frequently leads to itching. And PFIC as well as Alagille syndrome are really the two cholestatic diseases that have the most itching of all of them. We don't quite understand that because in biliary atresia, the biliary tree may be completely blocked, yet the children don't itch as much as they do in PFIC, but I'm sure this is familiar to all of you. So first thing to say is every child is different. And when we talk about personalized or precision medicine, we should really be talking about personalized or precision nutrition, because what works in one child to get them to grow and develop may not work in another child. Every child is different. Some of it's based on perhaps genetic modifiers. Some of it's based on life stresses that build up over time, environmental exposures. Again, we don't know yet how all of that fits together, but I just wanted to mention these are general guidelines, and every child really needs to have a personalized approach. So dietary lipids or fat, which are a major portion of calories, depend on bile flow, into the intestine, as do a certain set of vitamins called fat-soluble vitamins. And when bile flow is low, there's less bile in the intestine. The bile acids are the detergents in bile that help digest fat through a procedure called micelles, and this will lead to diarrhea, loose stools, poorly absorbed fat. Also, some children will have increased infections if they're undernourished. This adds to the stress on the liver, and it can then magnify the effect of the bile acids that are accumulating in the liver, and particularly on mitochondria and other parts within the liver cell. So this somewhat complicated but very informative diagram from a recent paper shows the three main conditions in cholestasis that contribute to malnutrition. And the first is a reduced intake. The second is maldigestion and malabsorption, primarily of fat and fat-soluble vitamins. And the third is the altered nutrient metabolism. And again, we could literally spend an hour on this slide and go through in great detail what each of these boxes means. But suffice it to say, there's various reasons why either appetite is reduced, or there's nausea or vomiting, or the child fills up early because their liver and or spleen are large, or their stomach isn't emptying. All of these things can lead to reduced intake. On the other side of the diagram shows what happens again when there's reduced bile flow. Not only is there fat malabsorption because of the bile acids, but you heard Dr. Verkade mention that the bacteria that are inside your intestines, the microbiota, the microbiome, they may alter because of cholestasis, and sometimes there's even overgrowth of bacteria that further inhibit normal digestion. Finally, if there's scarring in the liver and portal hypertension, that can cause a backup of blood into the intestines, which once again can further modify how the intestines work. So big part of this is malabsorption and maldigestion. Unfortunately, you can't easily add bile acids back into the intestine, or then you actually increase the amount in the body. So we don't treat with oral bile acids. I've been asked this many times. Can't we just give bile acids and then they won't have malabsorption? That would actually make matters worse in terms of itching and the toxicity of the bile acids to the liver. And then finally, the altered nutrient metabolism is much more complicated. We're still learning what that means in the face of cholestasis. But one thing we do know, that cholestasis causes an increased requirement for energy in the body. More calories are needed, and you'll see that reflected when we talk about treatment. So when you add all of this together, it's really amazing that any child with cholestasis can grow normally without some type of assistance. So what does this malnutrition cause? Well, first of all, immune function in the body depends a lot on your nutritional status. And if you're malnourished, you may have an increased propensity for a variety of types of infections, and diarrheal illnesses may be prolonged if you're undernourished. There's also a much bigger concern. As we all know, the child's brain grows and develops during the first few years of life, more so than the rest of their life. And nutrition contributes to brain growth and normal connections forming in the brain. So we also want to optimize nutrition, particularly early on in life, so that the child's cognitive development, brain development, motor development all proceed optimally. And then finally, there's very good evidence that if a child does need a liver transplant from advanced liver disease or end-stage liver disease, that their nutritional status before the liver transplant has a major effect on how long they stay in the hospital after the transplant, how quickly the liver recovers, and even things like rejection and survival. So we want to always optimize nutrition prior to a liver transplant without delaying the transplant. If it's needed, it's needed. And that's why, again, working in these areas and not wait till the last minute before a transplant is very, very important. There's also data backing what I just said, and I'm not going to show you too much data, but I think this is just one of many important studies. This is a study that looked at academic performance and cognitive and intelligence, if you will, post-liver transplant. In 93 children, they were before 10 years of age, and these children were tested after the liver transplant, so about a year after liver transplant. And in most cases, in most hospitals that do liver transplants in children, roughly 70% of the children had a liver transplant because of a cholestatic liver disease. And in this study, it was almost exactly 70%. In this study, full-scale IQ is intelligence testing through a variety of tests that we do in young children. And normal is considered somewhere between 85 and 110. 100 is dead normal in most studies. So 71 to 85 is mildly low. Below 70 is considered fairly low and concerning. And in this study, 30% of the children were between 71 and 85, and even 7% were less than 70. 42% of these children were in some special education already, usually started prior to transplant. What was concerning that over time, some of these deficits persisted after transplant. Reading was one that did improve, so that's very important. And the reason I'm showing you these data is in a study where they looked at factors that were present at the time of transplant that could have contributed to the lower IQ testing. What they found, these odds ratios are a way to calculate a risk for something in statistical terms. The higher the odds ratio, the stronger the risk. And as you can see in red, the strongest odds ratio predicting their IQ less than 85 was actually their weight at the time of transplant. And a Z-score is a statistical way to look at weight. Less than 1 is below normal, and less than 2 for a Z-score would be in this malnutrition category. So once again, if you look after transplant, it was the pre-transplant weight that was the highest predictor of what the child's IQ was going to be after transplant. So once again, just reiterating the importance of addressing nutrition before transplant. So first of all, how do we assess nutritional status? It doesn't really require fancy testing. I always tell my patients, there's always more tests we can do, but the question is, do they help us help your child? So simple things like measuring weight and length and looking at Z-scores, again, the statistical way to compare your child's weight and length to normal. These should be measured on an ongoing basis, but there's some problems with this, and that is that if your child has fluid retention, either ascites in their abdomen or in their legs, in their body, or even a large liver and spleen, that can increase their weight falsely. Their weight increases, but it's not a healthy weight, and that could make looking at their weight growth curve inaccurate. And there's a better way to actually assess that, and that's called anthropometrics, which really are a measurement of their triceps or subscapular, but we usually do triceps skin fold thickness. This is a little device that just pinches the skin over their arm and measures how thick it is. That's a measure of fat stores in the body. And something called a mid-upper arm circumference, which is really just measuring with a tape measure how the circumference around the middle of their upper arm, how big it is, and that's a measure primarily of their muscle in their arm, which again is indicative of the rest of their body. Dietitians do this all the time. We can hear from our dietitians in a minute, but these should be done at some regular basis. If the child's growing well, they don't need to be done very often, but particularly if we intervene with a nutritional supplement, sometimes it's better to be following these measures than, again, just the child's weight, because they may be gaining weight for other reasons. So we think in the first year, roughly every 2 to 4 months. If the child's already diagnosed with PFIC, it's probably reasonable intervals. As they get older, again, a lot depends on how they're doing. If they're responding, for instance, to an IBAT inhibitor and growing great, they may not need these quite this often. But we think in the first year of life, that is the critical time for brain growth, and we should really be vigilant. And you may have heard this term sarcopenia. I'm really not going to discuss it, but it means low muscle mass in your body, and there's a big emphasis on this nowadays as another nutritional measure. It does predict outcomes after transplant. It is related to something in adults called frailty. Again, we could have a whole talk about sarcopenia and frailty. These are not easily measured, although the people are working on some easy ultrasound measures that may actually be the way that we do this in the future. Currently, it's measured by CT scan, which has radiation exposure, et cetera. Not really prime time for clinical care, but ultrasound may be. So you'll hear more about this later. There is a very nice paper written here, the reference from 2019 in Journal of Pediatric Gastroenterology and Nutrition that you may want to look at. It's a guideline for nutritional support of children with chronic liver disease and goes through a whole sequence of, I think, how most of us advise families to get their child to gain weight with PFIC and other cholestatic diseases. And this includes aiming for about 130% of the requirement for that age for calories. And again, part of that's due to malabsorption. Part of it's due to that metabolism issue I mentioned. If they are not gaining weight or unable to tolerate this with a normal formula, normal diet, which most of the kids with cholestasis are not receiving a normal infant formula, and we then trend their tricep skin fold, mid-arm circumference here every 2 to 4 weeks, then we try to boost the diet. So if they're breastfed, add breast milk fortifier. If they need to be on a formula, make sure it's a one with a moderate amount of MCT oil that's absorbed well in cholestasis. Give them smaller volumes more frequently, and again, repeat these measurements to see if they are gaining true weight. In older children, there's a list of other things there. Now, if this doesn't work or they don't tolerate this, then we need to think of something else. And the next thing is really talking about some nighttime or daytime nasogastric tube feedings. These tubes can be placed. They're thin, they're soft, they can stay in place at least for a week or two, and we can give children formula while they're sleeping at night or in small boluses during the day. And once again, you then have to monitor and make sure this is working. And if this doesn't work after, here it says 2 to 4 weeks, some people might wait a little longer, then, particularly if the child's headed to transplant, we would consider putting in a central venous catheter and start them on some parenteral intravenous nutrition, again, to supplement, not replace what they're eating. And usually we give this at night, and we teach the families how to do this at home, and the child goes home on it generally up until the time they get transplanted. And here's just some studies showing that NG feedings do help. I'm going to skip that slide and just go right to this. This one shows you tricep skin fold in the top, mid-arm circumference on the bottom. On your left are children who receive this enteral supplement, and on the right are children who just had oral feedings. So the NG enteral supplement, you could see the lines are going up over time, and they're actually getting worse for children that weren't on the NG supplements. Word about fat-soluble vitamin deficiencies. I think you've probably all heard A, D, E, and K are very oily vitamins that require bile flow for absorption. Within months, children can be profoundly deficient. And at the time of diagnosis with PFIC, most children are deficient in at least one, if not two or three of these vitamins. Routine vitamin supplements that we give to other children generally don't work in cholestasis. Again, time doesn't permit, but here's just a study showing you kids with biliary atresia who are on routine vitamin supplements that were being used across the United States at our children's hospitals, and those below those boxes remain deficient. So anywhere from 10 to 30% of the children, despite being on what we thought were effective supplements, were deficient. So now we believe that many of the children, first of all, have to be monitored for these vitamin deficiencies. You don't want to wait for clinical signs to occur. So most of us will get blood levels at some interval, particularly during their first year of life. Those that have had a biliary diversion or an IBAT inhibitors theoretically may be more prone to vitamin deficiencies because there may be less bile acids in their intestines to absorb the vitamins, and they may need some supplements with specific vitamins, particularly lots of the infants are on vitamin D and vitamin K in addition. However, there are some newer combination vitamins, and I don't get any reward for mentioning this to you, but there's one called DECA Essentials, DEKA, Essentials, that contains a water-soluble form of vitamin E that helps the other vitamins be absorbed, and it has higher levels of the vitamins. And most of us are now using this for infants who remain cholestatic, not after transplant, but prior to transplant. And for many of them, it's avoiding having to use those extra single vitamins. And not only that, it's avoiding the expense of some of those extra single vitamins. This is not terribly expensive. There's a few other nutrients that we can talk about in the panel if you'd like. So in summary, nutritional assessment and therapies are really an essential part of managing any child with cholestasis, particularly those with PFIC. Fat-soluble vitamins, again, I really want to emphasize, need to be looked at and managed carefully. Aggressive nutritional support really can improve outcomes both pre and post-transplant, and neurocognitive outcomes, hopefully, as well, and that fat-soluble vitamin deficiencies really need to be addressed. So thank you. I hope I didn't give you too much information.
Thanks, Ron. We're going to save questions until the end. Now we're going to hear from...
Oh, this. Yeah. All right. Hi, everyone. I'm Liz. I'm a dietitian here at Cincinnati Children's Hospital, and I've been working with the liver team for over 4 years now. I'm just going to touch base briefly about the role of the dietitian on the interdisciplinary team. So Dr. Sokol talked a lot about the different nutrition problems we can see with kids with cholestasis, including increased metabolic rate and fat malabsorption, so higher calorie needs with our kids, fat-soluble vitamins deficiency and need for supplementation with that. So my job as the dietitian on the team is to help the team come up with an individualized nutrition plan for the patient. So each child is going to be a little bit different with what formulas they may tolerate and what nutrition plan that they need to promote good growth pre-transplant. So with that, monitoring oral intake first and optimizing oral diet first as the first line to provide adequate growth. If oral diet alone is not meeting the nutritional needs of the patient, then I assist the team with determining next steps for how to better meet nutritional needs. Tube feeds are the next step typically after optimizing oral diet. When thinking about continuous feeds versus bolus feeds with our patients, often
patients aren't going to be able to tolerate large volumes at once. And so often how we approach it here is initiating overnight continuous feeds, extending the time on those feeds as needed, and increasing the rate to better meet nutritional needs. If we've optimized oral diet and tube feeds and we're still not in a good nutritional spot, the next step is to initiate that TPN like Dr. Sokol had mentioned. I help the team with monitoring fat-soluble vitamins levels and assist with supplementation of that. So we usually monitor levels pretty closely here. If we're actively making changes to supplementation, then we'll usually recheck a level at least monthly to make sure that we're staying on top of the levels of our patients. Something that the team relies heavily on with making decisions related to nutrition are some of the arm measurements that I get on our patients. So the 2 arm measurements that we monitor pretty closely are going to be a mid-upper arm circumference and a tricep skin fold measurement like Dr. Sokol mentioned. We obtain those measurements here at Cincinnati Children's every 3 months on our patients listed for transplant. If a patient is at high nutrition risk or malnourished, I'll try to get those measurements more often than that. So some of our patients that maybe are in the hospital that we're following very closely pre-transplant, I'll try to get those measurements weekly on them, and we can assess, if the measurement is the same as it was the week prior or worse, then maybe we need to be a little bit more aggressive with our nutrition interventions. Something that I think it's important to note as the role of the dietitian on the team is helping families work through barriers to be able to provide their children with adequate nutrition. So many of the formulas that we want our patients to be on are very specialized formulas. And so the more specialized the formula is, the more costly it can be for the family. So some of the formulas that we have these kids on can be $40 to $50 per can of formula. And if a patient's requiring, much higher calories than other children their age, they're going to be going through multiple cans of those formulas a month. So making sure families are set up with the resources that they need to help subsidize the cost of some of these formulas, whether that's WIC or getting them set up with home care, communicating with formula companies to help get families these formulas. Another barrier that we've had to deal with over the past couple years are different formula shortages. So it's been periodically certain formulas are out of stock or there's recalls of these formulas. And so helping families navigate that barrier outpatient so that they're able to obtain these formulas and feed their child to promote good growth. Some of the formulas that we have these patients on as well are so specialized that you're not able to just find them at the grocery store on the shelf. And so, having to order the formula in through the pharmacy at the grocery store is just another step for families. And so making sure to communicate that and help families as needed with that. So our goal is to optimize growth and nutrition, minimize complications that our patients with chronic liver disease may be experiencing. Because as we know, a better nutritional status going into transplant leads to better outcomes. So it's very important to make sure that the dietitian is involved in the patient care and can weigh in and help make nutrition decisions to make sure that our patients are growing well and in a good nutritional spot going into transplant.
Thanks. So again, I'm going to talk to you today about access, nutritional access that my family has dealt with. And our PFIC journey, my daughter again has FIC1 deficiency, has always revolved around nutrition, both pre and post-transplant. So my daughter Tala was born in Dubai and had her first diagnosis of failure to thrive at 3 months old. And I was told to start supplementing with formula, which is good in theory, but if your daughter doesn't take a bottle, makes that quite difficult. At 6 months, Tala had her first admission for failure to thrive and had her first NG tube insert. She's had many of these over the years, and they never last more than 12 hours. She throws them up. But in that first admission, she decided that the NG tube was not for her, and she was going to take a bottle. So we could start MCT formula. I was super relieved. I could feed my child. We went home. Only to find out, living in the UAE, that we actually had no access to this formula. And it was only available for Emirati citizens at government hospitals. So I had to convince the manufacturer to import from Germany and sell it directly to me, which came at a hefty, hefty price. Tala had an official PFIC diagnosis at 9 months with genetic testing, at which point I quit my job, left a decade of living overseas, moved back to Canada to access government healthcare. We had a 3-month wait for access to healthcare because I'd been out of the country for so many years, but we finally had access to MCT formula and DECAs, so we were able to supplement her fat-soluble vitamins. As well, she had vitamin D injections at Sick Kids. Tala, at this point, still wasn't eating. She still doesn't eat orally. At this point, she would eat some purees that I would make her, only if it was in vanilla yogurt, only if it was a certain brand, only if she was watching an iPad. Lots of stress, lots and lots of stress for both of us, lots of arguing. She also vomited all the time. So even if she did eat, she didn't keep her food in. So failure to thrive, again, like completely off the growth charts. Our amazing Sick Kids hepatologist suggested a G-tube, but at this point I was super reluctant and like just didn't want another surgery. She already had an external diversion. It seemed like too much to manage. And I was convinced like, oh, it'll get better with age. Tala was transplanted at 4 years old, and I was told nutrition would probably get better again after transplant because things taste better when your liver isn't sick. Somehow it got worse. This was during COVID. She was transplanted in 2020, so the formula shortages again. So she doesn't eat solids. Now she's super picky on taste, and there's no more formula available. So at this point, we finally agreed, okay, we have to do a G-tube. There's nothing else we can do. And it was the best decision we have ever made. So in hindsight, I regret not choosing it earlier. It would have alleviated stress and arguments and so many tears, and potentially a lot of her oral aversion from fighting over eating. Tala loves her G-tube, especially for taking meds. So Dr. Hurdle, I believe, was talking about cholestyramine. That's a really tricky one, and we just give it through the G-tube. So Tala was able to finally get the formula feed she needed. We did overnight feeds using a pump, and she was back on the growth chart, and things were great. Summer 2022, she had a GI infection and spent 5 months in the hospital as a result. This required complete bowel rest and a central line insertion for IV nutrition. And at this point, we tried to wean the IV nutrition and start increasing the G-tube feeds again, but her bowels were just not having it. It wasn't gonna happen. And so we had the decision, after 5 months in the hospital, like, are we gonna stay here or are we going home? So we went home. I learned how to administer TPN at home, and it really helped her grow. So as much as I don't love that she has IV nutrition, her hair grew. She was less tired because the TPN nutrition was allowing her to get the exact nutrients she needed. She still hasn't tolerated formula since this infection in summer 2022. So our 6-month plan of being on TPN has turned into a 1.5 years, which is where we are today. Last year, her hepatologist at Sick Kids, who we're fortunate is also the medical director of the intestinal failure team, decided to try something new. And we've been giving IV nutrition through her G-tube. So we're actually trying to wean the central line IV nutrition and increase her G-tube feeds, but with IV nutrition through her stomach. So far, she's been tolerating it after a 1.5 years of not tolerating formula, and she is continuing to grow. So we still have lots of bowel issues. We've had obstructions and a midgut volvulus and narrowing, so many problems, but this seems to be working for us. And again, relating it back to access, because I live in Canada, because I have access to this specialist in intestines, because there's funding and coverage for TPN in Canada, we're able to do this. And I know from experience that's not the case around the world. So my final thoughts, fed is best has a new meaning for PFIC parents. So, you hear formula or breast milk. Well, it's like, no, it's actually NG tube or G tube or central line, and we've had all of it. And basically, you do whatever it takes to feed your child. Second point, nothing is forever. We're hopeful that Tala will not require IV nutrition forever, but if she does, that's something that we're just gonna have to overcome. I'm hopeful for less than 13 hours a day of IV nutrition, which is what she currently has. And I was in contact with a family recently who was really hesitant about getting a G-tube and just saying, like, this was the best decision for my family, reduced all of our stress on how I will feed my child, and she finally started to grow. So thank you.
So now we're going to, or can you all hear me? Yeah. Address some of the questions that families submitted. And so the first couple of questions are, do some foods, well, first one, do some foods intensify itching, or does a dairy-free or gluten-free diet help? And Dr. Sokol?
I'm unaware of specific foods intensifying itching if it's due to PFIC and cholestasis. If the child has some other food allergic condition that causes eczema or other rashes, they may itch on that basis, but that really is separate from the PFIC, and I don't think we even want to talk about gluten-free diets and milk-free diets here, since, again, those aren't directly related to PFIC, but individual children may or may not respond.
Thank you. And then another question is, are there particular foods that a child should eat or avoid to help maintain liver health?
So there's no specific foods necessarily that a patient needs to include or avoid in their diet to maintain liver health. What's important though, because the emphasis pre-transplant is always on, making sure our patients are getting in adequate calories and really pushing the calories. Post-transplant, you have to kind of rethink that a little bit, educate patients and families on, healthy habits to keep their liver healthy long-term down the road. And so setting kids up for success and monitoring their growth, making sure they're not gaining too much weight too quickly after transplant with their new liver.
Another question for Liz. In terms of fat-soluble vitamins, we had questions about what foods are best for ameliorating deficiencies of the fat-soluble vitamins.
So it can be it is very challenging to stay on top of vitamin levels with our patients that are cholestatic. So the focus is more so on just making sure getting in adequate nutrition and calories with foods, and not necessarily focusing on those specific foods that may be a little bit higher in those specific fat-soluble vitamins, because often patients are going to just require some kind of supplementation in addition to that.
Oh, and then we had a couple questions about guidance on timing of the vitamin supplements, morning and evening. Do some work best together, or others best taken apart?
So when you look at when bile flows from the liver and the time of day, the best flow is in the morning if somebody slept overnight, and particularly if they're not getting NG feedings at night. Bile builds up in the gallbladder, and the liver is kind of ready to go with breakfast. So you get maximum bile flow with the first meal of the day. So if possible, giving vitamins in the morning with a meal, because again, the vitamins require stimulation of bile flow to get absorbed optimally. Now that's assuming that there is a fair amount of bile flow. So for some children, it doesn't really make a difference what time of the day, but if you can do it optimally in the morning with breakfast, that's best. The other thing I should mention is that the fat-soluble vitamins should not be given with cholestyramine or iron or some other medicines that might interfere with their absorption. But as far as I know, they can be given at the same time or close to the time as an IBAT inhibitor, because that doesn't directly affect their absorption.
So another question is a practical one about help paying for vitamins, because at least in the US, a lot of times vitamins aren't covered because they're a supplement rather than medication. I don't know, Liz, do you have any thoughts on that?
Yeah, that can be definitely a barrier to maintaining adequate vitamin levels with our patients. I know here at Children's we have a vitamin fund that we can sometimes use with patients and getting our social workers involved to help cover and subsidize the cost of some of these vitamins. I think, Ron, you knew some.
Yeah, and also, again, I don't, this is purely recommendations based on taking care of patients, not the fact that I consult with some of these companies. But the IBAT inhibitor companies are working on or have in place some supplemental funds for families to provide them with dollars to help purchase vitamins on an annual basis. And I know that was in place with Alagille syndrome in Mirum. I'm not sure if they have such a program for PFIC yet, and I'm not sure if the other company, Ipsen and Albireo, have a similar program, but it's certainly worth looking into if your child is on an IBAT inhibitor.
Thanks. And then a question about how to add fats without causing diarrhea in a child. Ron, do you have any thoughts on that?
Well, every child has a limit to how much fat that they will tolerate, and we talk about supplementing with MCT oil and some other fat supplements if they're not absorbing fat well. I think every child is different, and you certainly don't want to have your child with oily stools in their diaper or become incontinent because they're on too much lipid supplement, oil supplement. So I think, again, you just have to titrate it for every child, not overdo it, and speak with your physician and your dietitian to come up with the best plan.
Thanks. And then one other question was suggestions for keeping track of medications and supplements and food intake, especially if a child, maybe one parent is helping in the morning, the other in the evening, and then there's daycare. And there are some apps that are designed to help with that, or a shared calendar, I think, were the practical suggestions that we had. I think that's a quick pass through the various questions, and I think we probably have to finish up, but I believe everyone here is going to be around for a while, so during lunch or breaks, certainly feel free to ask more questions.